Anyway, he's going to talk to us about scanning and the new imaging technologies that are available. So this is something that's really been important in prostate cancer over recent years, particularly in terms of diagnosis and staging of prostate cancer. So, Dr. Lindley.
Yeah, so like she said, I'm a radiologist at CARTI. I've been there about 3 years. Before that, I spent about 2 years at the VA. And before that, I did a fellowship in abdominal imaging at Cleveland Clinic. And then just before that, I was a residency at OU. And then before that, medical school here at UAMS. But Cleveland Clinic was great because it allowed me to do a lot of specific prostate imaging, which is one of the things that CARTI was looking for when they hired me and helped me get the job, was kind of my knowledge and training in prostate-specific imaging, which took about 2 years for us to really get started at CARTI. But here over the last year, we've ramped up, and now we're doing several a day with the prostate-specific MRIs. And you know, they're great for both kind of prospective treatment, in so much as, you know, you go to your doctor, you have an elevated PSA, and urologist will send them to us and say, we're thinking about doing a biopsy. Could you give us a specific target so that we can, you know, target the most suspicious part of the gland? And they usually do that in conjunction with their random 12 cores that they would do anyway, with the thought being that they'll do a 12 core like they do normally, and then they'll go back and usually do 3 additional runs through any specific spots that we find in the prostate that look the most suspicious from our standpoint on imaging. And this allows the urologist to increase their sensitivity so that if there is a malignancy there in the gland, that their odds of catching it are a lot higher. And it also allows them to target the most suspicious part of the gland so they can accurately stage the prostate cancer that's there. Because what you kind of don't want is maybe you hit the edge of a cancer and you get kind of a low-grade, you know, Gleason 3+3 malignancy, when it's actually sitting next to a more aggressive Gleason 4+4, and then you might undercall it and say, okay, this is just a Gleason 3+3, we can watch this, when actually it might need more aggressive treatment. And hopefully, and I think the data is proving us out, that with prostate, we can say this little 1 centimeter spot is the most suspicious area of the gland. So get that one 3 times, and maybe we can even mark up to 3 spots on the gland that look suspicious to us. If there are 3 to mark, we obviously don't make them up, but if there are up to 3 spots that we'll target for the urologist when they go in with their ultrasound guided biopsy, to hopefully they can accurately stage, you know, get the most advanced cancer that there is so they can give the most accurate and most beneficial treatment to the patient. And this also can help avoid repeat biopsies, which, you know, 10 years ago, if you had an elevated PSA, a lot of times they go in, you know, they biopsy, it might come back relatively benign. The urologist was not convinced because the PSA kept going up and up, so they go in, they biopsy again. Maybe they wouldn't get it that time either. A year later, they'd biopsy again, and then maybe they would finally get it. And they were kind of stuck doing that because they didn't have anything like this MRI that we have now. So the idea now is that prospectively, even before their first scan, or their first biopsy rather, we can go ahead and scan the prostate with MRI, find the most suspicious spots, so then the urologist can go in with his ultrasound, his or her ultrasound, biopsy the gland randomly, and then focally go after the most suspicious. And the technology is really cool. It allows, we can do the MRI scan at CARTI, and then we send the images over to Arkansas Urology, to Dr. Mooney or whoever is doing the biopsy, and then he can look at our MRI images and then find 3 points on the prostate and fuse that with his ultrasound. So then as he moves his ultrasound over the gland, he can look at my picture that I took, and it kind of lights up when he's right under the area that I'd marked for being the most suspicious, and he biopsies that. So he can kind of in real time look at his ultrasound image and compare that to what image I told him was the most suspicious, and that way we can work together and he can get hopefully the most accurate biopsy possible and hopefully avoid repeat possible.
So I've got to ask, how come my doctor doesn't want me to have a scan before the biopsy, which is in a week?
Well, sometimes they get into fights with insurance, and sometimes some urologists aren't as comfortable with the MRI, and they'd rather just go in, do a random biopsy, see what they see, and then problem solve after that with MRI if needed.
Yeah, but you're describing it as kind of, guessing by gosh, we're poking around in there. Maybe we'll get it, maybe we won't.
I don't want to get into, I don't want to talk badly about your doctor. I'm not sure what his rationale is.
I can answer that for him, and the answer is yes. I had biopsies for years and negative. My PSA kept going up. And finally, something similar to this came out of a prior technology, but was similar. And the first time around, they went in there and said, bang, you got Gleason 7. You better go get an operation. After years of negative results with pinning the tail on the donkey, the blindfold deal.
Yeah. Almost seems like a waste of effort.
Well, you have to have the machine that melds these two images together, the image that he produces and the one that the doctor produces when he runs the sonogram over your, so, maybe where you're going doesn't have the key or.
Arkansas Urology.
AR Urology has it.
They have it.
Won't do it a lot of times because of insurance.
Well, regardless, I can just tell you, it's been a 10-year deal with me. I'm now almost 5 years after my surgery. And so I started having biopsies over 10 years ago. And it took about 5 or 6 years to get one to show the cancer, but it was there all the time.
Good to know. Thank you.
And what I had was they actually took the they did the biopsy while I was in the MRI machine. It was prior to this fusion technology where they put the two images together. So they actually put me in the tunnel, took the image, took the biopsy while I was in the tunnel. That was the old, I guess, the intermediate technology. So.
Following that, can I ask you to explain that fusion technology? Do you actually do the MRI separately, and then that image goes to the doctor, and then he's got the machine that says,
yeah,
that's where I'm going?
It's the computing power. I don't understand the computer's aspect of it, but yes, we scan you a CARTI, and we have a special computer that, we look at the image, I circle it with a mouse, the 3 regions that I think are most suspicious, that goes to Arkansas Urology. He pulls that up in his procedure room, and he does an initial map of the prostate with his ultrasound, and then that gets fused to my image, and once it's fused, then he can move his ultrasound and basically look at my MRI image, and as it moves his ultrasound, it moves over my MRI, and then he gets right over the lesion in question, hits the button, biopsies what looks the most suspicious to me. And the idea is you don't have to go through all the random biopsies hoping to hit the cancer, that you get it the first time.
What kind of radiologic signs cause you to be suspicious of one area versus another?
Well, there's 3 different signs that we look for. MRI is called multiparametric because we use, the sequences are called T1, T2, diffusion, and we add some contrast to see what enhances. Basically, a normal prostate cell is full of fluid. That's what the prostate is supposed to do. It's supposed to be full of fluid, and that kind of secretes when you ejaculate, and that's the purpose of the gland, is to kind of lubricate the urethra as the sperm come out. So the prostate's supposed to be full of fluid. So a normal prostate has fluid signal all throughout the periphery of the gland that we look at. That's where cancer most often arises. When you have prostate cancer, it's no longer fluid because it's a ball of cancer, and it's dark. It looks completely different than normal prostate gland. So basically, we're just looking for a difference of, okay, here's normal on this side, here is dark, no longer fluid. This is more of a solid process, usually enhances a little bit. And we use this other sequence called diffusion weighted, which is a kind of a fancy term for saying how compact and how dense is this material. And And normal prostate is not very dense, it's just fluid, glandular tissue. Well, in cancer, it gets to be really densely packed cancer cells, and that also looks different than normal. And we're just kind of, basically which of these things is not like the other in the gland. And, they've done a whole bunch of research, and they've figured out 4 or 5 pretty exact characteristics of what prostate cancer looks like. And if it's, a textbook, we circle it. There's a classification system we use that the radiologists and urologists, powers that be, got together and made called PIRADS, which is prostate independent radiologic some or other, and it's 1 through 5. And we grade each lesion like how aggressive it looks. If it's a 5, then that's basically saying, that's textbook, ding, 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 that's the one you want to go for. If it's more of a 2 or 3, it's kind of like, it has some characteristics that look like cancer, but some that are more indeterminate, so this one's kind of a wash. Usually what we kind of communicate with the urologists, and we say, if it's a 2 or a 3, I'll still circle it, because if you're going to go in there and do a biopsy anyway, well, then I'll give that to you just to biopsy while you're in there. But I don't want you to go in there just because of what I said, because it's just a 2 or a 3. But if it's a 4 or 5, then you need to go in there and biopsy that, because that has enough characteristics that I'm significantly concerned that that's a malignancy that needs to be dealt with. So that's kind of how we communicate with the urologist, the 1 through 5 system, based on how severe and how bad it looks to us. And then, to bring it back to the fusion, then I circle what I think has the most, dangerous looking signs, and that fuses with the urologist so he can biopsy it during his ultrasound guided procedure. As far as why they don't do it, some insurances I think just won't pay for it prospectively, and it kind of has to, get a biopsy once, it comes back negative, PSA is still high, then the urologist can go to the insurance company and say, look, we biopsied it, his PSA is even a little bit higher now, we want to do the MRI to guide us next time so we don't miss it. If I were king of the world, I'd say, it makes a lot more sense just to get an MRI first, avoid that negative biopsy, or potentially negative biopsy, and then we can do 1 biopsy instead of multiple, and in the long run you save money, because you don't have to do multiple biopsies, pay for multiple biopsies, do the multiple pathologies, and it's a low risk of complication, but there are complications with prostate biopsies that happen. And
after the prostate's removed, are you able to see anything, cancer cells, when they say they have numbers coming up? I mean, can you see cancer cells after the prostate's gone?
we look for those in a couple different ways. Sometimes we will do an MRI of the kind of surgical bed just to see if some cells got left behind that then decided to grow into a tumor in the operative bed.
But you can possibly see that? So the question is when they recommend doing radiation after prostatectomy, how they just kind of told my friend here that it just kind of, they're shooting in the dark here, hoping they get it. But if you can actually see something, can't you then pinpoint where it might be? Or you have to wait till something grows before you?
For us to see it, you have to wait for it to grow to, it's half a centimeter or so, centimeters, that we could accurately see it.
Okay.
After they take the prostate out, like they know where it was, so they'll generally, if they deem it necessary based on how bad of a cancer it was, then they'll just irradiate that whole region of where the prostate used to be, with the idea that they're going to kill any residual cancer cell that happens to be left behind, to hopefully avoid it coming back in a couple of years and having to deal with it then. It's kind of why they usually use radiation.
But oftentimes they do the radiation a couple of years later, like him, when the PSA starts back up again, and rather than waiting for it to grow, if the indication is that that the velocity of the PSA, how fast it's growing, it's time to do the radiation, even if you can't see it. Is that?
Well, they'll usually do them like a search to try to see if it's somewhere else, because it can definitely reoccur in the operative bed, but prostate loves to jump to bone, It can go to lymph nodes, kind of in the pelvis, going up the retroperitoneum, and if it gets bad enough, it goes to liver and lung and other places. But prostate's notorious for jumping to bone. So if they take the prostate out, plus or minus radiating the operative bed, and if the PSA starts going up, then we'll do a bone scan, we'll do a CT, we'll try to see if it's an obvious spot somewhere else that we can then either treat that spot specifically or institute systemic chemotherapy if needed, or whatever the next treatment would be. But sometimes it's in the operative bed, but it could easily be somewhere else as well.
What tools do you have to look for metastasized cancer or reoccurrence in a specific area of the bed?
We can do MRI and look at the prostate bed really well. CT, if it's big enough, like over a centimeter or so, we could see that in the operative bed as well. CT is what we'll do to kind of check the head, through the pelvis. There's a good, easy scanning tool that takes, 2 minutes, so we can scan the whole body and get a good look if there's any big lymph node, a spot in your liver, a new lung nodule. We can look at the bones that way as well. We usually pair the CT with a bone scan to look for bone mets, because the bone scan has an agent that binds to actively remodeling bone. So if you have a metastasis to your bone is actively trying to wall it off and fight it. So you kind of have an active process going on at that bone right there where the metastasis is. So that'll light up on the scan. And then we look at that, look at the CT image, say, okay, there is a little something there. And then we can more definitively say, yeah, you have metastasis in this bone and nowhere else.
What I read is that in order for these tests to be able to detect a metastasis or a specific cancer or a lesion in the prostate bed, that your PSA has to get in the neighborhood of maybe a 1 or a 2, far beyond the number where you would want to initiate salvage radiation, say at a 0.4 or 0.5. So let's say in my circumstance where my PSA is now rising after surgery and I've projected in another 12 months I'll be at a decision point. I'll be at 0.3, for example, which is about where I'm going to be in 12 months. And I have the choice of either let it go to 0.4 or go to, at some point in time though I have to pull the trigger on the radiation. But what I've read about these tests that you're describing is that they're not accurate at that low level of PSA.
They're usually not at that low.
Okay, so I'm sort of caught in that catch-22 that yes, there's a test out there, but if I let my PSA rise to the point to where that test works, then I'm almost beyond the pale of availing myself of the radiation, so to speak, salvage radiation.
And that's a tough spot because you can...
I'm asking, not saying, I'm asking.
Yeah, no, I think when you're in that scenario, if the prostate's been removed and the PSA is, increases at all, then you kind of know that it's somewhere.
Right.
And then you're
I have positive margins, so in my circumstance, I know it's...
Yeah. So then you think it might be in the surgical bed, and then you can irradiate that, and you're kind of left with, okay, I can irradiate that and see if the PSA goes back down. And if you radiate that, it goes back down, well, then you can kind of say, okay, I can watch this for a while, and hopefully we got it.
Right.
Obviously, you'll keep checking your PSA periodically, but that would be the decision point there. One exciting new thing that's coming out is this PMSA molecule, the prostate membrane specific antigen, which we're hoping to get a CARTI here in the next year. And it's a specific molecule they found that's only on prostate cells, normal prostate and prostate cancer cells. And they're being able to bind that to a PET scan agent. And so basically you inject it into your blood, it circulates around your blood and binds to any prostate cell in your body. And then it gives off a signal that we can see with our PET scanner, and we can localize, hopefully the idea is prostate cells even at your describing the level you're describing at 0.03, 0.04 PSA level. Germans are doing a lot of the research on it. It looks really promising, and we're hoping to get that in Arkansas here pretty soon. But it's the technology just isn't available yet for us
Is
to
it
buy.
FDA approved anywhere in the US?
That's what they're going through right now.
Okay.
So, putting the two methods out there, the pin the tail on the donkey and the treasure map. Okay, do you have any feel or statistics for the difference between the two? In other words, those that go the treasure map route have it found much earlier, it's removed, doesn't need radiation, or anything like that, where you have statistics to say the difference between the two methods?
I don't, off the top of my head, I don't remember them, but yeah, the statistics are out there that it increases the yield of significant cancer just because you have a target to shoot for and you're not kind of going blind.
So if you get it early, and chances are you get it more completely, and then you're not having some of the issues we just talked about.
That's why we like to do it, is to avoid, like this gentleman was talking about, well, we had a PSA, we just got biopsy, oh, we finally got it. So now we know what we're dealing with. That's why the MRI is so great, is that hopefully we can eliminate the first three, and on the first one, we still run into the problem that even if we do an MRI and we say this lesion might be suspicious, we give it, like I said, on the 5 score, we give it like a 2, and they biopsy, it doesn't come back much, and then the PSA keeps going up, then we still might have to rebiopsy. There's one thing that is good about the MRI and kind of frustrating on the other, or depending on which side you want to come down on, is that it's designed and that we won't find like Gleason 3+3 malignancy. Because we don't want to find that. Because if we find that, then you're stuck with, what do I do with it? Do we watch? Do I go into treatment? Do I take the prostate out? And the MRI is designed to find clinically significant malignancy. Gleason 3+4, 4+3, or 4+4 or higher. So a Gleason 3+3 can still lead to an elevated PSA level. So sometimes you can have a PSA that's elevated. The MRI can look pretty negative, but you could easily still have a Gleason 3+3 there that would be found with just a random 12-core biopsy, and you would still need to get repeats biopsies after that on a yearly or 2-year, whenever the urologist deems it necessary, just to monitor your Gleason 3+3 to make sure that hasn't grown and morphed into a 4+4.
So, kind of a slightly different subject. My uncle was diagnosed with prostate cancer, and his doctor said, you're going to die of old age before this thing gets you. And his last PSA was 5,000 metastasized bone cancer and cancer died. So, are the doctors still that stupid, or are we better now?
They stratify it now based on age, other health factors. Yes, we are better than that now. If it comes back Gleason 3+3, then you kind of are at somewhat a decision point. If you're 85 with horrible heart failure and Alzheimer's, they probably just won't mess with it. If you're 40 and in great health, well, then we probably monitor it year to year and might take the prostate out with the thought that it's eventually going to grow to a more aggressive cancer, and you're 40 years old, potentially with 40 years in front of you, so we don't want to take that chance. It's more of an art than a science when you hit 70 and you're in pretty good health and you get a Gleason 3+3, then it's kind of, well, how aggressive do we want to be with this? Chances are eventually it will become more aggressive. That could be 20 years. That could be 30 years. That could be 5 years. There's no perfect map of, okay, it's a 3+3 now. There's not a map that says in 1.7 years that's going to jump to a 3+4. It's different for everybody. So